Okay, well, welcome back, everyone. This is another episode of MedChat Monday Healthcare Specialty Series, where we dive in to the different types of healthcare specialties that are out there and get the nitty-gritty so that we can be inspired to pursue these particular fields. Today, we have Dr. Bluestein, who's all the way up in Wisconsin, and she is a pain specialist, pain management specialist, studied and trained as an anesthesiologist. So Dr. Bluestein, welcome to the show. We're so excited to have you.
Well, thank you for having me. I'm really excited to be here.
So tell us a little bit about your background. How did you decide, well, we'll dive into why anesthesia and why eventually pain management, but tell us a little bit about your background, about why you became a doctor.
So I had exposure at a pretty young age. I had a sister who had quite a few medical problems, so I spent a lot of time in the hospital, in ICU even, and was fascinated by all the people in blue scrubs. I remember that very specifically, and I remember being in like the cardiac ICU and seeing all the drips going, and at that time knew that like pharmacology, physiology were things that really interested me.
This was when you were a young girl, I'm assuming.
Yes, exactly.
Okay, and was that the foundation for why you eventually pursued anesthesiology?
I would say that it was, yes, definitely. There were no other medical people in my family, so I didn't have any exposure that way, but I always really liked science a lot, and I really liked math, and I would say that, yes, I specifically decided on anesthesiology because I liked a faster pace, and I like to be able to use both my hands and my head. And I was deciding between emergency medicine and anesthesiology, and then chose anesthesiology.
It's interesting because, you were so young to have that foresight that that was the field that you were going to ultimately pursue. When you were in medical school, did you do any research in anesthesiology?
I didn't do any research. I did make sure to do a rotation in anesthesiology to make sure that I really wanted to do it, because I had that idea at a fairly young age. Well, if I have to tell the truth, which I should tell the truth.
Please be honest.
Okay. I really wanted to be a ballerina. Maybe some people out there may be aware of, medicine was my plan B. But when I realized that the ballet thing wasn't going to work out for me, I decided that I was going to do medicine, and right away anesthesiology was emerged as definitely a very leading possibility. So, okay,
so you get to medical school. I remember my first 2 years of didactics. We really had limited exposure to anesthesia.
Definitely.
So what did you find a mentor during those years, or was it later in your third and fourth year where you really got true exposure to anesthesia?
I would say it was definitely in my third and fourth year. I didn't really have any friends that were anesthesiologists or anything like that. I am on the faculty at the Medical College of Wisconsin, the Central Wisconsin branch, and I have had quite a few students approach me that they're interested in anesthesiology, and I share with them everything that I can to try to help them determine if that is a career that would be a good fit with their personality, their interests, and that kind of thing. So I definitely would have liked to have had that myself. I try to do that for people when I can, because those are very big decisions, deciding what specialty you're going to go into. But yeah, absolutely. For me, it was didactic for the first 2 years. Yeah.
So what is anesthesia? Like, what does the field entail? Because, when you're doing your third year rotations, you don't really have a month of anesthesia. You have a general surgery rotation. Sometimes they let you do a week with the anesthesiologist, and they let you dabble in it. But from my understanding, there are many residency programs that have large groups of anesthesiologists. So there really are a lot of opportunities if you're interested in the field, right?
Oh, definitely. When I first finished my residency in 1994, I'm dating myself there, but there was actually a shortage of jobs, but now there is a shortage of anesthesiologists. So there are plenty of opportunities out there right now. So And it's one of those things where, if you're somebody that that is coming in and kind of watching somebody do it for a day, it might not necessarily seem that complex. Like if you're watching a pilot fly an airplane, they're kind of making it look pretty easy usually. And because a lot of the time, I should say, things are relatively uneventful. But really what you're trained for is for the crises and for you use, the whole saying about using, 10% of what you learned 90% of the time, and then 90% of what you learned you only use 10% of the time. There's a lot of things that you need to know what to do if you encounter them, but the chances that you ever encounter them are very low.
And I'm assuming in your fourth year is when you really got true exposure to anesthesia. I'm assuming you did electives in different hospitals and really got broader exposure.
Right. One of the best rotations that I did, I went to medical school at UCLA, and one of my favorite rotations was night shift anesthesiology at UCLA. And so basically because there were fewer people around, I got to do more things than probably I would have if I had been there during the day. So that was a rotation that I really liked a lot. So yeah, I did several rotations, but you still have to fit in all of your regular required things too, right? So there wasn't, time to do a whole lot more than that. But I knew that's what I wanted to do, and it was a very good fit for my personality.
I was going to say that I would assume as a medical student you don't really get to do so much hands-on when you're doing anesthesia,
right?
As in other fields, right?
Right.
You're really watching and observing. You're not really getting to interact and touch the patient in the same way as the anesthesiologist. Exactly.
And that's where I was going with the difference between watching somebody do it versus actually doing it. When I first started my residency and they're walking you through, and I can't remember how long it was before my staff, I did my residency at the Mayo Clinic, and when my consultant anesthesiologist left me alone in the room for the very first time, I don't remember how long into my residency that was, but I remember being terrified.
Oh, so it was a few years until you really felt like all the responsibility was in your hands in essence.
Well, as soon as that person leaves, you realize that you can call them back quickly. There's a mechanism at Mayo to call them back quickly. But when they leave and you're there alone, it changes dramatically versus watching someone else do it, if that makes sense.
Correct.
It looks easy. It's like a lot of things. Depending on what's happening. Of course, if you have if you have a trauma that comes in and they're bleeding out and you're hanging blood and you have a bunch of different pumps going, then it looks really hard and it looks really stressful. But if it's elective cases, if it's young, healthy people, it can look relatively easy. If it's general anesthetics, though, like I said, that was the very first time that somebody left me alone. The patient was under general anesthesia. And as soon as my staff anesthesiologist left, I thought, what if the patient wakes up? Even though that's a completely illogical thing to think, So
what do you love about the field? Why should a young medical student be excited about this field?
So, as I mentioned previously, you get to use your hands, which I really like. You get to do procedures. So you get to do, things like central lines. You get to put lines in people's, veins that, go into their neck. You get to put in, like Swan-Ganz catheters, that go through the heart and out the pulmonary artery. You get to put in like arterial lines, into the blood vessels, arteries in the wrist. You get to do a lot of blocks. So you get to do, spinals, epidurals. You get to do peripheral blocks like interscalene blocks, axillary blocks. So you get to use your hands actually quite a bit. But yet you also still get to use your head. It's not, I don't want to offend anyone, but, it's not like orthopedic surgery where, they use their head, of course, too. But they're using their hands a lot. And, so that I feel like it's kind of a nice balance between, it's very intellectual. You really need to understand physiology very well. You need to understand pharmacology really well. I also really like the fact that it is it's very broad. So you need to understand neurology, cardiology, pulmonology, hepatology, nephrology. You need to really understand a lot of different functions of the body. So you have a pretty broad base for most people. Like for me, I worked with all kinds of different surgeries. So one day you might go from doing anesthesia for a heart bypass surgery or heart valve replacement surgery, and your very next case could be a cataract surgery. So you go from this big case where you have a bunch of different complex things going on. It could be a critically ill person, and then you go to something like a cataract surgery, which usually is pretty routine.
So there's a lot of diversity in terms of the types of cases you can be involved in. And
Right.
it also sounds like you're not on autopilot. You're not just sitting back, but you really have to think about what you're doing at different moments in a case, in terms of a surgical case.
Right, absolutely. The other thing that I really like about being an anesthesiologist is that although your time with the awake patient, generally speaking, although now for me, of course, doing pain management, they're always awake.
Which we will touch upon, of course.
Sure. But when I was working, strictly in the OR, which I started out doing pain and OR, and then I did just OR for a while, and now I'm back doing pain. But when I was doing just OR, what I also really liked about it is although your time spent with the awake patient is relatively brief, it's at a critical moment in their life. So what you do and what you say has great significance and great meaning. And I live in a relatively small community. I've had people come up to me, "Oh, Dr. Bluestein, you did my labor epidural. Oh, Dr. Bluestein, you took care of me for this surgery."
And they forget who the surgeon was, but they remember you because you're the first person they see when they wake up, or I would say the last person they see when they close their eyes and the first person they see when they wake up, right?
Exactly. And they know if they are knowledgeable, usually they know that we really do have their life in our hands. So they remember us usually.
And it's probably very rewarding after you see a patient wake up, after, a serious or even a minor case.
Yes. Especially the more complex ones where you really have to, especially now, people are living longer, so people have more medical problems, and so sometimes you really have to be quite creative. I think that's the other thing that I really like about it is it does, if you have a creative side, you definitely get to use that because sometimes you can't do just a regular, if there is such a thing as a regular general anesthetic or a regular MAC anesthetic. You have to get a little bit more creative sometimes with what drugs you're going to use, what technique, what approach. Sometimes they might not be able to be in a certain position, so you have to work with the surgeon to be, they have to be flexible too because the person might not be able to accommodate the way they normally do something. So you get to work with a lot of different people on the team as well. So you work, of course, very closely with the surgeon, but also with the surgical techs, the circulating nurse. You work with the PACU nurses. You work with the pre-op nurses. You're all part of one team that's taking care of that surgical patient.
So what advice would you give to a medical student who was just starting out and they're interested in anesthesia? What should they do to get started? What would be your advice?
I think what you brought up earlier is a great point, that if possible, if they can get a mentor, I think that's very, very helpful. If they can find somebody that they can, talk to that can help them get some exposure into the OR at a earlier stage so that they can, start kind of formulating their ideas. If they have any opportunity, as you mentioned, to participate in research. I can't remember. I did do research, but I don't remember exactly when that fell. I don't think it was in medical school, but it was just a few years ago.
It's okay. That's okay.
Hard to remember exactly. And also, I know some medical schools, I think that MCW is going to a pass-fail type system. But if you're not in a pass-fail system, you do need to have good grades. At least back when I matched into an anesthesiology residency, at that time they were quite competitive. So you did need to have a lot of other things that would be, beneficial, like the research or doing rotations where you would be able to get good, strong letters of recommendation from people specifically in anesthesiology.
Could you walk us through what residency was like? Is it a 4-year program? Is it a 5-year program?
So at that time, it was a 4-year program. I believe it still is. The first year, you are required to do either an internal medicine year, or you can do a transitional year, or at that time anyway, you could do a year of general surgery. I did a year of internal medicine, so I did 4 months of cardiology, 4 months of pulmonology, and then I did a few other things in there. It was a pretty common path that people took. You spend a lot of time in intensive care units because you need to learn a lot of the skills that are involved in being in an ICU. So you learn from intensivists also. And then starting your second year is when you start working in the OR and you start learning directly from the anesthesiologist. So the second year, so now.
And I'm assuming there's very early mornings because you're working in the OR.
Yes. In fact, it's interesting that you mentioned that, because when I told my family that I was going to be an anesthesiologist, and this was after I really decided, this was not when I was younger, when they probably just thought, oh, okay, that all sounds great. But when I said, no, this is really what I'm going to be matching in, the first thing that my mother said was, you realize you have to get up early in the morning for that, because I'm a night owl.
Well, that's a good question. Is this field really meant for someone who's a morning person?
So I do think that people who are naturally morning people probably have it a little bit easier than those of us who are not morning people. Although I quickly adapted to a very, very early schedule, and I routinely got up at 4:30 in the morning. And before I would be going to bed at 4:30 in the morning. So I really had to change up my schedule. But it was worth it, because, yes, exactly. Like you said, you have to get up very early, because you have to get there. You're there long before the surgeon gets there. You have to get all of your various equipment ready. You have to be reviewing your assignment and getting your room set up. And, there's a lot of, depending on what type of rotation you're doing, that can impact things also. But yes, your day starts very early. Generally, it also ends earlier than a lot of other people's. Back when I did residency, they didn't have the 80-hour work week restriction. So it was long hours.
It was longer hours.
Longer hours. Yes, exactly. It's still long hours. Yes, definitely.
Okay. So then your third and fourth year was a continuation in the OR?
Exactly. It was a continuation in the OR, and your last year, you are really supervising the other, more junior anesthesia residents. And what I liked about studying at the Mayo Clinic was that you are not, when I was at UCLA, oftentimes I was in VA hospitals or county hospitals, things like that. We never saw our staff, like never. You were usually learning from somebody who was maybe a year or 2 years more senior than you. But when I was at Mayo, you were learning most of the time from the faculty. But then your last year, for example, when you're on call, your faculty would be in the hospital and you could call them and wake them up if you needed them. But you really were in charge. You had to come up with a plan with your junior resident, and which was good, because otherwise when you leave and you no longer have somebody to, look for help and guidance or bailing you out or whatever. And there were actually some people at Mayo who would do things as a test to see how you would respond. I had faculty that, for example, you have pipeline oxygen that's, plugged into the ceiling. And it happened once where my faculty purposefully took that out to see if I would quickly react. And they were right there.
Because it's flammable. Is that the reason?
To make sure that you would be able to immediately assess what's happening and, okay, I better switch to my tank or reconnect it, or, they would do a lot of kind of testing things like that, just to make sure that.
So if you're a medical student, you're in your third or fourth year, how do you, are there types of residency programs you should be looking for in terms of training? Like what's your advice looking back? Where's the best place to train? Not necessarily, the Mayo Clinic, I know that's one of the top places, but what type of program should one be looking for?
Right. That's a great question, because I think that the balance between getting the appropriate amount of guidance but also being the appropriate amount of freedom, because you need to have that. Now, I should also point out that at the time that I was going through my residency in my last year and these things were happening, first of all, it didn't happen every day. It was just, every so often they would do things just to make sure that you would know what to do in the event of an emergency. It was like a way of somebody simulating a certain type of circumstance, which now they have simulators for that. So that's the other thing I should point out is that simulation training is now part of required training for anesthesiologists. And it is very similar to being a pilot, where a large percentage of the time things are relatively uneventful, but if things are not going well, it can be very, very serious.
It's great that they have that now.
Yes, it's wonderful. And I've done some simulation training, and it is really impressive. I did simulation training at Northwestern in Chicago, and the people who, it looks like a real person. The simulated body like opens and closes its eyes. It really, and the monitor, everything, the OR is set up like a real OR. And the pulse oximeter is going off, and you immediately feel like you really are there. Like, if you're doing something on a computer or something like that, it can be hard to really feel that. Your own pulse often goes up, like in a cardiac arrest type situation. It can be hard to think calmly, but these really advanced simulators are wonderful because they really help people to have that kind of practice without putting patients at risk.
Of course, and that's a great thing.
Yeah, and it's a fabulous thing. So like at Northwestern, when I did this training, the people that were there as part of the training faculty, their acting skills were outstanding because, they were acting as if it was absolutely 100% real, which made it feel completely real. And it was a whole team of people like you would normally have. And so it really does simulate well different types of crises. And that's important because you may never in your life encounter certain things, but if you do, you need to know how to handle it.
So you should certainly you should certainly look for programs that have this type of intense training where they teach you to be in these moments and prepare you for, something that could potentially be dangerous.
Yes, definitely.
Was all of your training inpatient? Did you have any opportunities to do outpatient as a resident?
So when I was a resident, I definitely did do outpatient. It wasn't at Mayo, it wasn't a completely separate independent facility like probably a lot of places are now, but I definitely did do plenty of outpatient. You rotate through different things. So you might spend some time in Ent anesthesia. Now, at first I thought, well, why Ent anesthesia? Well, they're operating, up around the nose and the mouth and things like that. So you have to secure the endotracheal tube differently. You have to, the patients present different types of airways, and it is the anesthesia factors are different for ENT surgery than they are for, orthopedics, neurosurgery, cardiac surgery, things like that. So that's the other thing that I think is important, is to make sure that you rotate through all those different specialties. And yes, outpatient is very important because there's different expectations in terms of wake up time and, readiness for departure from the facility and things like that.
So you get to the end of residency. What are the options in terms of what are the next steps? Do you go right into practice? Should you consider doing a fellowship?
I think that it's important to consider doing a fellowship. I think that, especially nowadays, I think that probably is a very important consideration if you think that you have a specific area that you would like to focus in. I think that is very beneficial, and I don't think that very many people go back and regret that they did a fellowship. It seems like and I did locum tenens for about 4 years, so I've also worked with anesthesiologists for a more extended period of time, but I also have exposure to a lot of different anesthesiologists because of when I did locum tenens. And I don't think I've ever run across anyone who did a fellowship who didn't think, wow, I'm glad I did this, because it gives you more opportunities. So for example, if you do a cardiac fellowship, it's not like you can't do regular cases, you certainly do, but it gives you additional opportunities in cardiac anesthesia. Now, on the flip side, a lot of people are eager to get, their first, quote, regular job, because at that point they've been in school for a long time. So I completely understand that. And I personally did not do a fellowship. But at that time that I finished residency, I think it was much more rare to do a fellowship.
So how did you eventually venture into pain management? Was that the plan after residency, or was that something that you later discovered?
It was something, as I mentioned, is something that I did initially when I first finished my residency. I was in a very small hospital, and basically it was kind of a 1.5 person job. So my colleague would be there for a week straight, then I would be there for a week straight, or 2 weeks, something like that. And then during that week, you were on call for that whole week, and then you were off for a week, recuperating basically, because it was too busy for one person, but not quite busy enough for 2 people to be there all the time. So that's how we divided it up. So when I was there, I did do pain clinics. So I did treat people for various different chronic pain issues at that time. Then in between then and more recently,
Well, by the way, would you say that was early in the field? Because now pain management seems to be like a growing field, and I mean, a lot of people I know going into anesthesia want to do pain management eventually.
Right. So I would say at that time when I finished my residency, it was not the pain crisis, opioid crisis, all of this that we have now. So it was definitely something that, yes, there were pain clinics and things like that, but it was, I think, de-emphasized as compared to what we have now, and also a lot less sophisticated. We just couldn't offer people as much as we have now in terms of either interventional options or non-interventional options. So then I spent that time, in the OR, and I had some of my own medical things come up, and I always had been fascinated with pain and how pain processing works, and I always had also been fascinated with using nutrition to help treat various different conditions. I had been really fascinated by being an anesthesiologist in the OR. I saw many, many, many thousands of patients. I cared for many, many thousands of patients. And you would be looking at them as time went on. You'd be looking at them like on the EMR, and then you would go see them and you would think, wow, on the EMR you look pretty good, but in person you don't, or vice versa, right? Or you would see somebody who is in their 80s and they're still riding a bike, and you see someone in their 30s who's doing really poorly. So I started kind of putting more things together and really realizing the impact that our lifestyle choices make. And this was also before the whole real age era of, well, your chronologic age is this, but your real age is either more or less than that.
Yeah.
So I became really fascinated and really interested in these things a long time ago. And if I had time, I would actually talk to my patients before surgery and, maybe give them some other suggestions or, chat with them about some different things. And I did, Dr. David Warner from the Mayo Clinic is a very big advocate of quitting smoking, and he has developed some really great programs. So I evolved my way that I would talk to people about smoking, because when I first started mentioning this to people, I could tell that it wasn't going over well. And then I realized that I was doing it in a very judgmental way, and that I needed to change my approach if I wanted to have any type of success.
So your practice now is it's a combination of pain management, but also holistic medicine. Right.
And like motivational speaking, teaching, interviewing type of thing, because I can come up with the best plan in the world, but if somebody's not going to follow through with it, it doesn't do them any good.
So you have your own private practice, I'm assuming now.
I do.
And what does a typical week look like? What are the types of cases that you're seeing and the types of patients that you're interacting with?
So I'm seeing patients with chronic pain. I hung my own shingle. I decided that if I was going to do this, I wanted to be able to do what I thought was appropriate. And after doing locum tenens for a number of years and seeing how different places worked, I decided that if I could make it work, great. If not, I gave it a shot. And it's been going really, really well. We have lots of people, coming in. We have no shortage of patients right now, that's for sure. There's no shortage of people, of course, in pain, which, that's sad. That's not a good thing, of course. But also
as someone who's pursuing the field of pain management, it's an exciting time, because there's so many baby boomers that are aging every day. I think there's like 10,000 every day that are turning 65. So there's a lot of opportunity for an up-and-coming young doctor.
Exactly. Lots of opportunity. Whether you want to do interventional pain management or whether you want to do something more like what I'm doing now, which is more working with lifestyle and diet, and certainly I prescribe lots of medications. I definitely do that, but it's also, like you said, more holistic. So yes, lots of opportunities. There's definitely plenty of need, that's for sure. And I anticipate that there will be for a long time. I don't think pain is going away anytime soon. I don't think persistent pain is something that, we're not around the corner from a cure for it, in my opinion.
But I think you're totally right, by the way, that historically doctors would prescribe steroids, or they would prescribe opioids to take care of pain. And what's interesting is you're an anesthesiologist. You're trained to use medication to treat pain, but you're approaching it in a very holistic way, and that's a great thing for young doctors, young medical students to see that there's a combination of the two when you're practicing as a pain management specialist.
Right, absolutely. And the other thing that I think is really exciting about medicine in general, but for me, anesthesiology and pain management, is how it is absolutely lifelong learning. So I spend a lot of time still going to conferences, presenting at conferences, exchanging ideas with colleagues, and that's what I like about it. I mean, there's never a dull moment. So
what are some of the most exciting things that you're looking forward to in the field? What are some of the big advancements that people should be excited about?
So one of the things that I'm most excited about is doing genomic testing on people, looking at single nucleotide polymorphisms. So I have a lot of patients that have connective tissue disorders, like hypermobility disorders. So they're like Gumby. Their joints are more loose than normal.
And ehlers-danlos as well, right?
Yep. And ehlers-danlos is one of those. If you look at hypermobility disorders as like the biggest umbrella, ehlers-danlos is one of those hereditary disorders of connective tissue that falls under that umbrella.
Yeah.
And so we can do genetic testing and looking for the defects in formation of collagen for those things. But we can also do genomic testing looking at the single nucleotide polymorphisms. So the DNA pairs, we now know that like at different locations in the DNA strand that they have different implications. So for example, it's not uncommon for my patients to have problems with their mast cells, with degranulation of mast cells, and having problems with histamine release and the other factors that get released when you degranulate mast cells. They'll have problems with itching or gastrointestinal complaints.
Now, this sounds like rheumatology. So could you merge the two for us so we have an understanding of how you take your training in pain management and treat these patients?
Right. So and I'm also describing now, of course, something that a geneticist would do. So that's where I am trying to use the best tools that I can develop to help people get the most, mileage out of, working with me. So if they are interested in doing this genomic testing, then I will do that. But most of them don't. I mean, some of them do, but a lot of them don't. The difference is that then we're starting out treating you as if you metabolize drugs the same as everyone else. Other than the fact that, of course, I do normally check people's liver function and kidney function early on in the process. So, but that's one exciting development in the field. The other really exciting thing is this whole concept of the mast cell, which I'm leaving tomorrow to go to a conference that is all about mast cells, and it's really exciting because the leaders in that field will all be there, and we're all sharing cases and learning from each other. It's a workshop. And we'll have lots of opportunity to learn from each other, and we're getting a better understanding of how these cells impact pain because they're located near nerve endings. So when they degranulate, they definitely impact the sensations of pain, and they cause a lot of symptoms that are invisible for a lot of people, and so a lot harder for the average physician to diagnose and treat.
Dr. Bluestein, this really seems like you love what you do, and it seems that you truly picked the right profession. I want to thank you for the time that you spent with us. I think that the listeners are going to be inspired to consider pain management, going through the anesthesia route first. is going to be a great option. So thank you so much for taking time out of your busy schedule.
You're very welcome. Thank you so much for having me. Really appreciate it.
Of course.